David, did you want to intro or should I go ahead? All right, I'll go ahead and share about the vaccines. Once again, we have 78.3% of New Mexicans 18 and over, and 61.5% of New Mexicans 12 to 17 years old have received at least one dose. So that is super exciting. We're doing about 1 percentage point every week on improving, and that's just way better than we thought we ever would do. So congratulations to all New Mexicans. We have 68.4% of New Mexicans 18 and over fully vaccinated, and 48.9 12 to 17-year-olds who are fully vaccinated. If you look at the slide here on the side, just want to congratulate all of New Mexico, our DOH team, all our providers and pharmacies throughout the state, and everyone who's gotten vaccinated to keep the state safe. If you can see here, want to congratulate the Southeast. You're increasingly improving your vaccine rate, so that's really exciting. And as my colleague, Dr. Ross will be sharing later on, that's really helping our state have fewer cases than other states and is also protecting our children who aren't vaccinated yet. We'll also be having a dashboard. We're working on a dashboard that will start updating to reflect the additional third doses that people who are immune compromised are going to get. So good job, everybody. Next slide. We also want to thank all our mobile teams, both our New Mexico National Guard and FEMA teams. They have been going all throughout the states and have given over 27,000 doses in places of high social vulnerability, in places with racial and ethnic equity to really inequities where we're actually improving vaccine equity. So we want to let everyone know that if you're a community organization, a church, if you're in a difficult to reach location, if you want to have a mobile team, you can still visit vaccinenewmexico.org to request a COVID-19 vaccine team for your event. So we're really excited about that. That's one of our ways we're getting to reach everyone in New Mexico. Next slide. This is another exciting update, is that thank you to everybody who participated in August. We had a 58% increase in vaccine administration. That's over 50,000 extra doses this last month. So for those of you who got vaccinated this past month, the $100 vaccine incentive deadline to sign up is this Friday. So if you got a first or second dose of Pfizer or Moderna, or your one shot of J&J during the month of August, you can get your $100 incentive still if you haven't signed up. The $100 incentive, if you can get it by email, by text, or physical mail. And if you get it by email or text, you can only spend it online. And if you get it on physical person, you can spend it anywhere, online or offline or in physical person. You have to register by 5 p.m. on September 10th. And you just go to the vaccinenewmexico.org incentive registration site. So sign up if you haven't yet, and you'll get your $100. Next slide. So we want to go over booster doses again. I know we talked about it last week, but once again, booster doses, the purpose of them is really to boost the waning immunity you get over time from the vaccine. And who qualifies? No one yet qualifies. And the other question is, when can I get the booster? And we're still waiting for final data and recommendations from the FDA and CDC later this month. And for those of you who listen to NPR from Dr. Fauci also said, yeah, we're waiting for FDA approval. We're gonna be able to do boosters soon, but like I said, we're waiting on all the data. Next slide. So I guess the big question that people have is when we will be getting these doses. And we aren't actually ready to fire the starting gun yet, because we don't actually know where the starting line is yet. It could be anywhere between 6 to 10 months is what the CDC says. So we're just waiting on that. When you look at this line though, here's the line of when we started getting doses in December. You can see that it steadily goes up and then slowly goes down. So just imagine 6 to 10 months from now, we'll be following that same curve, depending on if it's 6 months or 8 months or 10 months. And then remember back then when we did long-term care facilities and healthcare workers first, then people with comorbidities, and teachers, essential care workers. So basically just remember that little curve, and that's pretty much what's going to happen when we go forward. It's just roughly that's what it looks like. But just so you know, at the DOH, we're planning, we're getting ready. Our hospital systems, thanks to all of the hospital systems out there that said that they would be ready to give their doses to their workers, that's going to be a huge help. And we've already been talking to our aging and long-term services department. They're working with our pharmacies and other providers and delivery systems, but basically we're going to need all hands on deck. So we really want to encourage all providers who are ready to give doses again to sign up to do so. Next slide. We're actually really fortunate that it's convenient that flu vaccine is coming at the same time as COVID, because you can actually get the flu and the COVID at the same time. You can also actually give it in the same arm at the same time, not in the same place, but in different places on your arm. Also, just a reminder to all the parents out there who are getting their kids vaccines as well, just a reminder that you can get the COVID vaccine together with the childhood vaccines. And really, it's really not that uncommon to get multiple vaccines together. Next slide. And then once again, a call or a plea to all providers out there, and also to people to reach out to their providers for your next COVID-19 vaccine dose. We're trying to move away from these mass vaccination sites to really just make vaccines like a regular part of flu and any other booster shots that you're going to get, that you can get in your provider offices. Ask your provider if they currently give COVID vaccines, and if not, when they'll be making booster doses available. We're also working with our medical teams and pharmacy providers to be ready when we are starting to get boosters again. And if you are a provider and you're like, yes, I want to give vaccines to my patients, sign up at takecarenewmexico.org. We have teams who are ready to support you and help you get signed up to do the vaccine. And we're just really grateful for everybody and all their efforts to keep on giving the vaccine and keeping our communities safe. Thank you. And now I'm going to turn it over to my awesome colleague, Dr. Christine Ross.
Thank you, Laura. So good afternoon, everybody. It's my pleasure to join you again this week for this COVID-19 update. I have a few slides to share with you on our COVID data. So the first one I think everybody's familiar with. This is our statewide epidemic curve. And of course, everybody's well aware that the COVID-19 pandemic continues to impact the state of New Mexico and the United States in general. So this is showing the number of new cases, and we plot it over time. And what we're looking at is over to the far right, which is the most current dates. And although we certainly don't want to celebrate too early, I do want to say that we're happy to see that there is a deceleration of growth in new cases. And what you can see is the semblance of a possible plateau there in this small mountain on the far right of the slide. Again, it's my job to worry, so I certainly don't want to celebrate too early, but I am happy to see this semblance of a plateau. So I do want to say thank you to all New Mexicans who are following COVID safe practices and other preventive measures to help us flatten this curve. Of course, with the Labor Day holiday, we could see an impact in our case counts over the next week or so. So we're going to continue to watch this very, very closely, but are very hopeful that this plateau will then turn into a decreasing trend of new cases. Okay, let's move to the next slide. And so this is a slide from our partnership with some modelers at Presbyterian. So they use our epi surveillance data to calculate what we call the R effective, or what's known as the effective reproduction number, or the average number of secondary infections that result from one infected person. So what we're calling this on the slide is the spread rate. And what you're seeing here on the slide is they have calculated the R effective has trended down to 1. And that also is something that we really like to see. And we want to see this number continue to drop underneath 1. So basically, when this R effective is greater than 1, COVID-19, we expect that it will spread exponentially. And if the number is less than 1, we expect that that the spread will be slower and cases will decline. So again, this is a move in the right direction. We're hoping to see this drop below 1. And again, I think the box is indicating that we got the word out about the highly infectious nature of the Delta variant and its predominance in New Mexico, and the need to really to follow preventive measures. We reinstituted a public health order asking everyone to mask indoors. All of these things together appear to have made a positive impact. Okay, let's go ahead to the next slide. And so this one you're also familiar with. This is data from our vaccine report, where we take the surveillance data looking at cases, and also surveillance data looking at hospitalizations. And then we take vital records information looking at deaths, and we match that data with our vaccine registry data. So this slide is showing the proportion of cases, hospitalizations, and deaths by vaccine status. Or in other words, is this individual vaccinated, fully vaccinated, or not? So the yellow part of the bar represents unvaccinated individuals, and you can see that this segment of the bar for cases, hospitalizations, and deaths are predominantly among this category of individuals, or unvaccinated individuals. And so again, this data is just a constant reminder about the protection that the COVID-19 vaccines afford us against this virus. So let's go ahead and move to next slide. And this is also data from that same report. And what's different here is it's showing a trend over time. And the green line is representing unvaccinated individuals, the yellow representing vaccinated individuals. We're going to ignore the red dotted line for now. But again, the take-home message is that the driving force in the surge of cases that we're seeing in New Mexico is unfortunately, is among unvaccinated individuals. Let's go ahead and move to the next slide. So we wanted to talk a little bit about demographics, particularly age. So what are we seeing here in New Mexico with regards to a breakdown in age? So this is a slide from the demographic epidemiology report looking at daily case rates over time. We wanted to include some of this data because we have been receiving a lot of questions about what's happening among children. And what I first want to show with this slide is the big blue arrow there. I'm trying to indicate where the Delta variant became the predominant variant that we were sequencing in New Mexico. And then you see the surge in cases after that. And this is among all the different age groups, which are broken down on the right-hand side. So just as a reminder, we do genomic surveillance by conducting what we call whole genome sequencing. And this is of specimens that we receive at the state public health lab. And we also partner with several labs, including folks at UNM and Lionel, several other labs, including CDC, to conduct this surveillance for variants of concern. And what we see here is this clear pattern of when the Delta variant was the predominant variant. We unfortunately had this real surge in cases amongst all different age groups. What I want to zone in on, though, just want to point out here is the yellow line, which is school-age children, age 5 to 17, and you can see that that line is quite high. So case rates are quite high among that age group. 0 to 4 is the black line, which we've also seen a significant increase in the case rate, though it is lower than those among the 5 to 17-year-old age band. And then you can move to the next slide, I believe. Okay, and this again, zoning in on some of our pediatric data. We're looking at the number of pediatric cases. We just wanted to point out that overall, of all the cases that we've reported to date, that pediatric age range has accounted for about 15, almost 16% of the cases, though currently the number of pediatric cases is taking up a larger proportion of what we're reporting out. And in fact, over the last 7 days, this is 24%. And I believe the week before it might have been closer to 25% of our total case count. The graph on the top are individuals 0 to 4, I believe. Sorry, I think the age is obscured, but that's 0 to 4-year-olds. And then the graph on the bottom is 5 to 17-year-olds, both again experiencing a real acceleration in the case rates, though it's more dramatic in the lower graph there amongst 5 to 17-year-olds. And let me show you this last slide where we zone in on this a little bit more. And again, what I want to point out is the 5 to 17-year-olds are that yellow line. And I think what's interesting here, we want to show you that the case rates in the winter surge, which is the big mountain in the middle of the slide, case rates were very similar among 5 to 17-year-olds and then also 65 and over. So very similar case rates. And then you can see that case rates declined nicely over time. And we had quite we could call a lull for a period of time and then hit our lowest numbers in, I'd say, end of June, beginning of July. And then they really took off with this surge, which is being fueled by Delta. But what's really interesting is you see this divergence of these lines where the pediatric age group 5 to 17 in the yellow continues up very high and is nearly the same as the 18 to 34-year-olds now. But the 65 and over have, although they increased, you can see it's not nearly as high as this school age group. And we think, obviously there's a lot of differences between those groups, but one thing that really sticks out is vaccination coverage. And we know the 65 and overs have a very high vaccine uptake or vaccine coverage in this age group. And certainly we do not see even half that rate in this younger age group, given that you're not eligible for vaccination right now until the age of 12. So this is some of the reason why we are anxiously awaiting approval, FDA approval for these younger age groups so we can help temper the number of infections that we're seeing right now. So let me move to the next slide. I believe this may be all of the slides, and I'll turn it over to Secretary Grace.
Thanks so much, Christine, and Laura as well. Christina, you get my unofficial award for the coolest slide of the week with that last slide. I think it really demonstrates the progress we've made in the state with respect to vaccination and how that's protected us. And there's more news on that I'll go over today in my slides. So I'm going to talk about hospitalizations and deaths and testing and sort of batting cleanup here for this press conference presentation. Let's move on to the next slide, Brianna. And this is our self-scoring for our hospitals. You can still see that we're barely in the crisis standards of care range now. We have not had to deny anyone medical treatment. We have had, as you'll see in a minute, very full ICU beds, but we are still managing to move people around the state, move ventilators around the state, move high flow oxygen tubing around the state, and move treatments around the state in order to make sure that everyone is still getting cared for. So we have not issued any kind of official crisis standards of care declaration. And while it's really good news that we're seeing a plateauing in the case curves that Christine, Dr. Ross just showed you, we still anticipate another 2 weeks of hospitalization surge as we've seen in previous waves of the pandemic. So I'll still be sitting on the edge of my seat through close to the end of September now, till I think our hospital partners will and DOH facilities will feel like we're actually getting out of the woods. Next slide. These are maps of how many ICU beds were open yesterday morning around the state on the left, and regular general medical beds on the right. We've been putting a lot of our attention to the southeast part of the state, where you can see yesterday there were only 2 ICU beds left in the whole southeastern part of the state. And on the right-hand side, you can see slightly more general medical beds. Generally, those fill up by noon every day. And so we're those 2s and 1s go down to 0s, but then of course, people are discharged in the mornings, like this morning. And so we have more open beds, but we're basically putting as many people into beds as we have open beds at the present time, and expect that to continue again, as I mentioned, for another couple weeks at least. Next slide. Modeling, we're seeing something really, really interesting. And what we're seeing is actually the modeling that we've been doing is no longer predictive of hospitalizations. And so I'll show you 2 of the models we use. I don't want to go into too much depth here, but on the left, we have the Lionel Los Alamos National Lab hospital projection model with the blue line, what they were projecting, and the circles being what we're experiencing. And you can see the trend of those circles is going now in a different direction than the original modeling. On the Presbyterian slide, it's a little more complicated to read. The blue lines refer to all hospitalizations. The red lines just ICU beds. Let's just look at all hospitalizations. You can see the solid blue line going up to about 2 weeks ago, then that dotted line, which is our previous projection, but then the actual hospitalizations were lower than we were expecting. That gap, maybe Brianna, you can show it between the top dotted line in blue and the blue curve. The cases actually, now the solid blue line, the cases actually were lower than that and now are projected to trail off. So there's something about our response this time, or the Delta variant, that we don't fully understand, that has created this change in the shape of the curve. Some of us believe that New Mexicans responded more quickly, and more of us responded to getting treatment for a positive COVID test with symptoms and a risk factor. And I'll show you those curves in a second. That reduces hospitalizations by 75% in high-risk individuals. And that would certainly be enough to explain the difference between either of these 2 sets of curves you see on this slide. But just to reassure you, we continue to model, and now we'll, as you see Presbyterian has done on the right, and Lionel we'll adjust our modeling algorithm to adjust for these changes we're seeing in real life. And again, given the choice of having the little circles, the actual cases be below what we projected or above, we're happy to take having the cases be lower than we expected. And we still are up against it in terms of our resources in hospitals. On the next slide, we're going to look at cases pediatric cases. This is just to follow up on Christine's slides, but also questions from reporters last week about what are we seeing in pediatric cases. The peds groups are the black and orange lines and Halloween colors at the very, very bottom of the graph. You can see they're barely, the percent of cases in kids that are admitted is extremely low. Now, the percent of cases in kids you saw is much higher, but it's much more unusual for children to be admitted. If you squint and stare really closely at the last part of that orange curve, you'll see a slight uptick there, so that we have seen a slight increase. But over the course of the entire pandemic, we've only had 281 kids hospitalized, only 2 in the past week, and only 4 deaths. Of course, 1 death is way too many, and we all feel that even more deeply when it's a child, but only 4 deaths in the entire course of the pandemic. And we're going to talk about why that might be, mainly because you all asked us and we didn't know the answer. You've been asking us, how come we're not seeing the same kind of increase in pediatric hospitalizations that other states are seeing? And we do have an answer for you today on behalf, courtesy of the Center for Disease Control, that I'll go over in a couple of slides here. Next slide, please. So we are seeing a 10 times increase in hospitalizations nationwide in the age 0 to 4 group. We've all been reading about this in the news. We also know that unvaccinated adolescents, 12 to 17, are being hospitalized 10 times more frequently than their fully vaccinated counterparts in the 12 to 17-year-old age group. And so just again, a reminder to wear a mask in public indoor spaces, all schools. This is for everyone ages 2 and up. It also extends to child care centers, of course, as well. And gotten a lot of emails from people describing the difficulty of keeping a mask on a 2-year-old. I've spent some time with my 2-year-old grandson recently, trying to keep a mask on him. I do feel your pain. And remember, a little bit of masking is better than no masking at all. We all know that it's hard to keep 2-year-olds occupied doing anything you want them to do, but the extent to which we can keep kids masked in schools and child care centers, the better. And of course, everybody who's eligible for a vaccine should be vaccinated. Now, the next slide shows this national trend of increased hospitalizations, and you can see that the top group is that 0 to 4 with a 10-fold increase in hospitalizations from, like basically, I think 0.02% perhaps, or even less than that, to 10 times higher, still a low rate. And then you can see the numbers for 18 plus year-olds, adults, and 5 to 17. So young kids, 0 to 4, being hospitalized at a higher rate than even adults. And so again, a reminder to keep those masks on when around others. Next slide, please. So here's the answer to multiple reporter questions about how come we're seeing hospitalizations increase so much in children and adolescents in the rest of the country, and New Mexico is not. Is there something wrong with our data here in New Mexico? We did not believe there was, but what the CDC has found now is there's a very strong correlation between low vaccination levels of people 12 and older in a state and pediatric hospitalizations. And the ratio is approximately 4 to 1. They've got these little hospital icons. Brianna, on the next slide, if you can go to that, we can show you the actual data that came from the CDC article. I know it looks a little complicated, but basically they divided all the states in America up into 4 quartiles, from the highest vaccination rate states to the lowest. You can see New Mexico, we're privileged to be in one of the highest vaccination rate states for 12 and older, still in the top 10. And then you can see in the lower quartiles, if you just scan that, all of those southeastern states that we've seen with such high rates are there. Now, in the table above, I want to focus on the right-hand column, the hospital admissions. The hospital admissions for the highest quartile that New Mexico is in, we're the reference point. And you can see second highest quartile, 40% more hospitalizations. But then you go to the second lowest and lowest quartiles, it's 3.5 to 7.5 times more hospitalizations per 100,000 kids age 0 to 17. And so we think this is the answer to the question. We postulated this last week, that maybe our high vaccination rate is helping. And just to remind you, and we all need things that we can feel good about in this pandemic, but every single person listening today who's gotten a vaccination, you've protected yourself, your family, but you've also protected children in New Mexico, and the immunity of adults is now being shown to protect immunity levels in kids. So we're proud of this. We're happy to see these results. We're sorry that it's so bad elsewhere. I don't have time today, but in the left-hand data column there, you can also see that your chances of being a child going to an ER in a lowest vaccination rate state are 2.5 to 3.4 times higher than it would be in a high vaccination rate state like New Mexico. Okay, so that's an update on kids and hospitals and an explanation that I think is pretty good about why we're doing well. Let's go to the next slide. And unfortunately, we are continuing as predicted last week. I told you we'd see an uptick in deaths, not just for the prior week, but for multiple prior weeks. And you can see that those last 2 weeks in August, where I think we're in the teens and 20s, and now they're in the 30s. And we will continue to see that upward trend in deaths for another 4 weeks after that hospital trend. So that's sad. Our hearts go out to all the families. You know, I was touched by one of my coworkers in state government who died of COVID over the weekend. Somebody I knew very well, who had been to my house to help me get my new laptop up and running. And so, you know, these deaths really make an impression when, you know, you can look at 4,000 deaths or more, and it can be very abstract, but when someone you know or you know well passes from COVID, it really has helped me to see even more clearly the real impact that it's had on individuals and their families. Next slide, please. I want to talk about one slide here about treatments, and then 2 slides later about non-treatments. And so we're doing well with treatments. On the left, this is the antiviral agent remdesivir, the number of doses given in hospitals. Our hospitals are very savvy in the treatment of these moderately ill people that end up in the hospital. And almost everyone now is getting some form of antiviral treatment. Almost all of those are remdesivir. And you can see that our hospital partners have really kicked up the administration of that as they see new cases. Each course of remdesivir is like 6 to 11 doses. So the number of people treated is, we'd have to divide to get the people treated. And then on another very positive figure is a very significant uptick, thanks in large part to our media partners who have been getting the word out really well about monoclonal antibody treatment. If you have a COVID-19 test that's positive and you have symptoms, and you're either greater than 64 years old, or you're obese, or you have any risk factor for serious COVID, and that's heart disease, lung disease, high blood pressure, immune disorders, you should really seek out treatment. It lowers the hospitalization rate by 75%. And we believe that some of the decrease in hospitalizations that we're seeing, not all of it, but some of it is due to people seeking out treatment and avoiding hospitalization, and in fact, avoiding death as well. Next slide, please. I wanted to go back over testing. It's a big issue. Our reporters had lots of questions and challenges last week, so I want to make sure we give you the latest data. Next slide, Brianna. Our test positivity rate finally back down below our 7-day rolling average target of 7.5% and staying there. I want to see that curve go back downward. I don't like the idea that it's parallel to the target line. It's very, very close, a couple dozen tests away from popping back up again. For those of you who are tuning in for the first time, And there might be some of those folks. When that blue line is above the green line, that means we're not fully keeping track of all the cases in New Mexico and able to track everyone with COVID. And so we're happy to see that getting back under control. Next slide, please. A number of tests done per week. We've had certainly some record days, as you can see there, but a very, very nice trend upward from 4,000 to 5,000 tests, 3,500 to 5,000 tests in almost the entire month of July, to over 10,000 tests almost the entire month of August, and on average over 10,000 tests a day. So that's doing very well. Again, I think on the next slide, I'll just remind everybody when you should get tested for COVID. No, it's going to be the slide after that. So in this slide, just we do monitor turnaround times. We expect our in-state labs, which are pathology consultants, SLD, Southwest Labs, Tricor, to be as low as they possibly can. When folks go out of state, then there are necessary delays with transportation. But in general, we're doing reasonably well in terms of test turnaround time. Other, because this question is frequently asked, is just a conglomeration of a couple hundred other doctors' offices, hospital facilities that do their own testing, and we aggregate those all into one group that has been growing. Next slide, please. So yeah, here's the reminder. COVID testing remains available at no cost. You should not be being billed by your insurer for the testing. Get tested if you have symptoms or you've been in close contact to a positive case, if you live or work in a high-risk congregate setting, and of course, if you're scheduled for a hospital procedure, you will hear from the hospital. Not many elective procedures being done these days, but this no longer depends on vaccination status. So close contacts, vaccinated or not, please get tested. Please seek out testing. There's if you go to findatestnm.org, it will walk you through the steps. Also gives you a link to Vault if you just want to collect the specimen in your own home. In addition, there are new opportunities for testing springing up. On our next slide, you can see the fact that the CDC issued a warning, I think like 10 minutes after our press conference last week, saying that there is now a supply shortage for rapid COVID tests. A lot more people are requesting the rapid test. They're saying, please get a PCR test. In the meantime, this is just from a laboratory website, but plan ahead. If you're one of those people getting surveillance testing weekly, you can schedule that weekly through Vault. You could go to a Curative site, and numerous people that I already listed in the other category. And every day we seek out and try to add more and more of these testing sites to our website. But many days now, we've had over 100 different places open and offering testing. May not be at the exact hour or time that you want, but we still feel like we're doing a reasonably good job keeping up with people's testing needs. Next slide. And in addition, the market is expanding. Abbott, their Binax Now card, there's new data that suggests if you're getting weekly testing, you may want to just buy a kit of these. Right now, they're available online for $150, and then they run you run the test on yourself at home. It could be done on anybody 4 or over. We're not really advertising for them, but just illustrating this. And we are actually working to develop a partnership with eMed where the state could provide some of these tests for individuals as well without the same charge. And so we're working on that now. But I think over the next couple of weeks, we will see CDC reports they're closely monitoring the supply chain for these more rapid test options. And I think we'll see a reopening and many more of these tests available on the market. So just another option for those who require testing. Next slide, please. Also came up in the past couple of weeks, we are launching a new program for testing in the schools. We have a new partnership with the Premier Medical Group. And we've got a $63 million grant from the federal government to fund this testing to help keep our schools safe. So all the testing and resulting will be provided through the schools, the regular testing for teachers and staff, but this will also be available for students, parents who want their students tested, parents who want their children tested in school will have some access for this as well. And the schools have to apply to participate. And we've already, of course, told our public education department about this and have been working with them on this. But if there are schools watching this that are not signed up for the program, we'd encourage you to do this. It's free. It's provided through the state. Another option for increasing the amount of testing we're doing without burdening existing testing resources that are close to full right now. Okay, we're on the home stretch, I promise. Next slide, please. I want to talk about misinformation. You know, every week I talk about some tragic episode. To my knowledge, and this is unofficial, but I've heard about anyway, the first death in New Mexico from someone who took ivermectin, thinking it was a reliable treatment for COVID. You can see the things here that it's used for. It's only taken internal to the body for people with river blindness, intestinal strongyloidiasis, which is a worm that inhabits the GI tract. Believe it or not, I've treated people for this in my career. You can put it on your skin for lice and rosacea, but it's mainly a veterinary medicine for parasite infections in animals. It is not authorized or approved by the FDA. There's a cult following for this drug. The MAD has looked at it. Medical advisory team has looked at it 3 times. We don't think there's evidence for it to be effective in treating COVID by any stretch of the imagination. And now we have one person who we believe may have expired from an overdose of the drug and another in the intensive care unit in our state. Next slide. Just again, a reminder, we're giving you the poison control number. If you know someone who's taken ivermectin, I might have mispronounced it earlier, ivermectin, encourage them to call poison control. The animal products are very, very concentrated. You don't have to be a veterinarian or a physician to know that the dose you might give a horse for a parasite infection would be much larger than what you'd give a human being. These medicines, ivermectin interacts with blood thinners, which can cause bleeding, and a list of symptoms there that I won't read through. And overdoses can lead to seizure, coma, that should say, or death. So please be careful. Please support us, media partners, and warning people of the dangers of ivermectin and the fact that it's not a safe treatment, and that we now are seeing, at least we are hearing about, and hopefully we'll have more documentation in the coming weeks when we get the death certificate about potential fatalities. All right, I think with that, the state fair, just a reminder, people need proof of a completed vaccination series or a valid exemption. I just reread the public health order, and generally it consists of a doctor's note for exemption related to medical or disability issues, or a clergy person's note with respect to a religious exemption. And if you have that exemption, then you have to have a COVID test taken within 48 hours of your arrival to the fairgrounds, and that you have to have evidence that it's negative. If you're under 12, you do not have to comply with these requirements. And if you're not vaccinated, you don't have an exemption, then admission is not open to you to the state fairgrounds. All right, let's close it out now with a reminder. Please, if you're not vaccinated, get vaccinated. Continue to stay home and be very, very cautious around closed indoor spaces. Please wear masks. If you think you've been exposed, get tested. If you have a positive test and symptoms and risk factors that we've been through today, seek out the treatment. It will dramatically lower your risk of hospitalization. And then the usual washing our hands, keeping surfaces clean, keeping those masks on, particularly indoors, and don't forget preventive health care. And with that, Matt, I'm going to turn it back to you, and we're open for questions.
Great. Thanks so much to all three of our principals. And as usual, we'll take questions in the order in which they appear. So please do raise your hand if you'd like to ask a question. And just a reminder of our new modified protocol for the press conferences. We're not going to limit things to one question per person. So we will cycle through multiple times as needed. And our request to you then would be to not cluster multiple questions into one. Please just do ask one question at a time to allow our principals to focus and offer a clear answer. And we'll cycle back through as many times as we need to within a reasonable time frame. So with that, we'll begin with Jeffrey Plant, followed by Julia Goldberg, and then Stella Sun. Jeffrey, you are unmuted. Please ask.
Thank you very much, Matt. This is Jeffrey Plant with the Silver City Daily Press. A couple of weeks ago, I heard from our critical access hospital here in Silver City that the administration there was eager to work with their employees who were not yet vaccinated to find or help them find and accommodate health or religious exemptions. They've managed to increase their vaccination rate by 2 percentage points from 85% to 87% as of a couple of days ago. But if an employee declines to be vaccinated, the administration indicated that they may well be put on PRN or on-call status. Have you heard of other New Mexico hospitals doing this? And related to that, is this hospital worker vaccine mandate permanent, or does it lapse with the health order, or how does that work in the long term?
Well, thanks, Jeff. Good questions. I did circle back on your question 2 or 3 weeks ago on the bed reporting and talk with the CEO there. So thanks for raising that. I want to congratulate. 87% is still a pretty good vaccination rate. Not as good as the Department of Health. Just saying, we're at 88%, probably up a little higher than that now. The public health orders, can be renewed. So I think the intention is not to have this be a temporary requirement for hospital workers, but a permanent requirement. And it is the position of the state to leave the administration of how this works with employees to local hospital leaders in this case, or school leaders. So we're leaving it up to hospitals to make those decisions. We support them in those decisions. Hospitals can come up with their own rules for documenting exemptions, and we leave that to them. And I think I just remind people that as frustrating as it can be to us to have folks who remain unvaccinated, this is America. It is a free choice. People are allowed to make those decisions. It's not up to me to pass judgment on their reasons for getting vaccinated or not. On the other hand, it is important for the state to weigh in particularly high-risk situations like hospitals and congregate living situations like nursing homes and assisted living facilities and correctional facilities where we have some of our most vulnerable people, actually most of our most vulnerable people in New Mexico. And so that is where the state comes in terms of a requirement for those populations, but we're leaving the administration up to individuals. And Christina, I saw you nodding your head. Do you want to say anything more about that?
Oh, sorry. No, I'm just full in agreement with what you've said. I don't think
Okay.
I have anything to add.
Okay, thank you.
All right. With that, we'll turn to Julia Goldberg, followed by Stella Sun, and then Dan McKay. Just a friendly request, if you wouldn't mind calling out your media outlet when I call on you, I'd appreciate it. Julia, you are unmuted.
Thank you, and thanks for letting me ask the first of 3 questions. I have been reading that nationally there's a bit of an increased demand for extracorporeal membrane oxygenation or ECMO treatment. I wondered if UNM is still the only hospital with that resource and if it's being used. I know last year there was a man on it for over 90 days or something of that sort. So I didn't know if it was in use and or if it was something that would be available to people in other states where there's a shortage or they don't actually have that treatment. Thanks.
Yeah, that's a really good question. I don't know the answer to it. I thought Presbyterian was doing ECMO at least earlier on. I think it's just a way of getting oxygen in people's blood that's different than putting a tube down their throat. The oxygen molecules are actually put into the bloodstream to provide needed oxygen to organs. We have not had a discussion about that in some time, so I will check back with our medical advisory team and let you know what that status is. I do know that the university has ongoing cases, and we'll check with Presbyterian and see if there's others. I don't know, Laura, or do you have any idea about that at all? Okay, so sorry about that one, Julia. Matt, should we have a rule that if we don't know the answer whatsoever to a question, we let the reporter ask a second one?
Absolutely. Yeah, roll again.
Excellent. Best rule ever. Dr. Patahan, I know you mentioned that you're going to update the vaccine database to include the booster shots, but I wondered if you had any raw numbers. When I asked in August, I was told there were about 30,000 people who'd marked immunocompromised on their vaccine registry profiles, and that jumped to about 57,000 if you added cancer registrants. I understand not all of them would be eligible, but I'm just wondering around how many people have received their third shot.
About 10,000 people have received their third dose or additional shot for the, yeah.
Okay, thank you.
Sure.
Okay, with that, we'll turn to Stella Sun, followed by Dan McKay, followed by Cedar Atanasio. Stella, you are unmuted.
Good afternoon. Thank you so much for holding this. And thanks for sending the variant data earlier today. I was hoping you guys could address the Mu variant. Fauci says we don't really need to lose sleep over this variant, but we're seeing a lot of reports of it nationally. I know it's kind of a mutation in the spike proteins, correct me if I'm wrong, and that it may make it resistant to antibodies produced by the vaccines. I'm hoping Dr. Ross, Grace, or Dr. Petajon could please elaborate on this. Thank you.
I'll just give a quick introduction. And, I think that every time a new variant comes out, there are 4 things we need to know. How effective is it compared to other variants, which we just went through in big time with the Delta variant and much more effective. 2, does it cause more serious illness, hospitalization, and death? And interesting, what we're seeing is it seems like it's causing more serious illness and hospitalization in unvaccinated populations than vaccinated in the Delta variant. So sorry, I don't want to confuse this answer. So 3rd, what about treatments? Do treatments work? And then lastly, what about vaccines? So you hit on the key question, because obviously a variant that comes through that's completely resistant to all the existing vaccines would set us all up for a different kind of coronavirus infection going forward. I don't have any data in any of those 4 categories for you on the Mu variant, and we get our variant report tomorrow, Stella, so at 8 o'clock in the morning. So I can make sure that one of us, maybe Matt, you can take this assignment to get Stella any update about what we've seen. But I know in the last sampling last week, we had not seen any Mu in the state. But Christine, do you have any more updated info on that?
Yeah, well, I would just add that I think it's a little too early. I think I would agree with that quote from Dr. Fauci. I think we don't have enough information yet to classify this as a variant of concern. From my understanding is that it's still a variant of interest, which means we're going to keep an eye on it. I think that in the United States, it's a very tiny proportion of the specimens that have been sequenced to date. So it has been identified in the United States. And yes, this is an update for you, Secretary Grace. We have sequenced this here in New Mexico as well. And again, this is why we're doing this type of surveillance, to try to keep an eye on this evolution of the virus. How does it change? And then we keep an eye on what's happening globally to understand the impact of these variants in different locations in the globe. So I think currently it's too early to say, but I think it's a fantastic question. And we're definitely going to be watching this very closely.
Yeah, Stella, too, like if you're looking for something to keep you awake at night, you can do what I do and think about our hospital capacity in New Mexico over the next 2 weeks, because I think that is a subject worthy of sleep loss, at least in the next 2 weeks. And as weeks go by, we'll learn more and more about Mu and Lambda and other variants that we're starting to see. Thank you.
Thanks, everybody. Next, we'll turn to Dan McKay, followed by Cedar Atanasio, followed by Chris McKee. Dan, you are unmuted.
Hi, thank you for taking my question. It's my understanding that a top official at UNM Health Sciences has suggested people resume masking outdoors. I'd be curious to hear from one or more of you whether your thinking has evolved or changed on masking outdoors. Would you recommend that people start wearing masks if they're outdoors exercising, or if they're, say, going to the UNM football game or kind of a congregate setting? That's it. Thank you.
Now, I'll start on this and we'll see what my colleagues have to say. I think the answer is it depends. We're going with the CDC guidelines. As you know, in New Mexico now, there is no major formal recommendation except for unvaccinated people in more crowded settings. Personally, I think with Delta, there is increased infectiousness of that variant. So if I'm going to be outdoors in a crowd myself, I'll wear a mask. I just will, because I just spend most of my life in contact with people 75 years and older in my practice. I mean, that's not my whole life anymore. And we have relatives who are vulnerable. So I'm mainly concerned about me not getting something that I then spread to others. So I think it depends. And, you know, my wife and I still are doing our regular walking program in the dark in the morning, and we don't wear a mask for that anymore. But if I were to go to a football game, in a packed crowd, I'd probably wear a N95 and wrap around eye protection. I don't know. Christine and Laura, what would you do in a crowd outdoors? And it's okay to have different answers than me.
No, I think just in general, I agree with the idea that it depends, right? If you're outside exercising alone, I do not think there is a need to wear a mask. But then I think you gave the other example of if you're in a densely crowded outdoor event, that calculus changes. Because if you don't have, certainly if you're around a lot of individuals in public who may be unvaccinated, and we know that we have really high levels of community transmission right now, then wearing a mask, even outdoors in a situation where you are in a crowded event or in a large group of people. I also think the calculus changes depending on your individual level of risk. It's really a different calculus for somebody who is older or somebody who has really complex medical problems that put them at high risk for severe outcomes. And then it really changes the calculus as well. And then I think those folks need to be very cautious right now, given the high levels of community transmission. And I think masking when you're in public around a large group of people, whether it's indoors or outdoors, I would recommend masking. So I think that was probably consistent with what you just said, Secretary Scrace, that you do. Anyway, and over to you, Dr. Petto.
Yeah, I would do the same. And, I think also like taking care of the people that you're around, like if you have little kids that are at risk, and you could bring it home, or elderly parents. So yeah, I would definitely do the same.
All right, thanks everybody. Next we'll turn to Cedar Atanasio, followed by Chris McKee, followed by Brittany Costello. Cedar, you are unmuted.
Hi, thank you, Dr. Ross, for that overview of student cases. And we saw a little bit of information about what last year's holiday can tell us about this year. Could you sum that up for us? For any parent who's thinking, is my school gonna get a bump in cases in the next couple of weeks? What could we say, with some confidence about the holiday and the effect on case rates for children?
Well, as an epidemiologist, I try not to predict the future. I try to look at the information in front of me. So the forecasting bit, I'll let Secretary Grace chime in as well. I think that we know really clearly that there is a delay after an event before we pick up a surge in cases. And then there's another delay before people who become seriously ill end up in the hospital. So remember, there's an incubation period that we have to wait through, and then folks have to seek a test, and then we can pick up what's happening. So could there be a bump in cases related to Labor Day gatherings? Yes. Absolutely, I can say that with confidence that there could be. Can I tell you that we're going to see it? No, because that depends on so many different factors, including human behavior, right? So did people mask when they got together? Did people gather within their household versus outside their household, etc.? I'm going to pause because the screen is frozen, and I'm not sure if I'm frozen.
We can hear you, Christine. You can keep going.
Oh, okay. So I would say we're going to keep a really close eye on this and see if we see this uptick in cases. Though I already shared with you some really exciting or what we hope information where we do see this plateau. And I believe even today we're going to report out our new cases, and they've actually dropped even further than we've seen prior. So that's great news, but I think you're going to have to stay tuned because we could see a bump, but I can't predict. There's so many different variables. So I think just stay tuned over the next week. And let me see, Secretary Grace, if you want to add.
Yeah, I was just going to add another angle on this about the seasonality of the coronavirus, which I personally think there have been innumerable inaccurate predictions about. Like, I think we all sort of know that, oh, this virus is going to be really awful in the winter. Well, we've had 3 basically, or 4, depending on you count it, if you want to count the first one. But we've had 4 peaks, none of which have been in actual official winter months, although we were on the tail down of our worst peak in November, December last year. And then we have these variants that are major variants that don't seem to be obeying any rules according to the season of the year, or the weather, or things like that either. I really hope that coronavirus becomes a seasonal virus. I would love that. That would really help us better prepare and shift our workforce and be ready and get on a regular vaccination schedule that we could all get every fall, and we need coverage for 6 months, and then we'd be good for a year like we are with influenza. So I think the only thing Labor Day this year and last year have mainly in common is the fact that people get together on that holiday. But, we were at a nadir actually in our epidemic curve. Labor Day last year, we're at a peak, this year. And so I am hopeful that it will become a seasonal trend, because that would enable us all to protect ourselves much better, I believe. But I don't think we're anywhere close to that just yet. And so far, all of the predictions really have not ended up with big peaks in the winter.
Thanks, everybody. Next, we'll turn to Chris McKee and Brittany Costello. And if I could ask if everybody else could just lower the, yeah, thank you. You saw where I was going with that. Once we get through Chris and Brittany's questions, then I'll ask everybody to raise hands again, and we'll go back through the sequence. So thank you for that. Chris, you are unmuted.
All right. Thank you guys very much. Hopefully you can hear me here. I wanted to ask specifically a question that kind of came out of the discussion we were having here in the newsroom about breakthrough cases. The question was about sort of the double infection of COVID. I know anecdotally we have sort of heard it out there that people, some people say, oh, I got COVID twice. But it seems like perhaps that is maybe a hard thing to track. So I was just wondering, does the state by any chance track the number of sort of double infections out there? And is there a number maybe you could share with us about that? Thank you.
Another really interesting question. So, so we call those what you said, double infection. We call reinfection, and we are tracking it. I don't have a number that I can share off the top of my head. If I had anticipated this, I could have provided a number. So I can get back to you on that. We are tracking it. And yeah, it does appear that reinfection is rare, but it is documented. It does appear to happen, though again, it's very difficult to tease this out from people who may be, let me give you an example, may be immunocompromised and tend to shed the virus over a longer period of time than we would expect. And perhaps we pick this up with frequent testing, surveillance testing. In the example I'm giving you, I'm thinking of people that could reside in a long-term care facility, like an older individual who could meet that description. So it can be very difficult without adding genomic sequencing information to sort out, is this a real infection, a real reinfection, or are we in fact just picking someone up who they've tested positive again, and it's because they continue to shed the virus over a long period of time, longer than what we think is the majority of folks, where we believe most people stop shedding that virus within this 90-day time frame. So excellent question. And yes, we are tracking it. We're working with CDC as well, and they are gathering information from different states. And I think you're going to hear more about this as time goes on. And certainly as we move through the pandemic over a longer period of time, I think the reinfection question will be one that you will spend more time on.
Yeah, Matt, I raised my hand because I have a question for Christine on this topic. Is that allowed?
Absolutely.
Okay, I'll lower my hand. So Christine, I remember we were going through this a lot and talking about it at some press conferences in the spring about reinfection. And at that time, the CDC still hadn't nailed down a time period from the first infection to the second, and it was 90 or was it 180? And I think they were kind of at the time leaving it up to states to do that. Do you know if that's changed at all? Or I don't mean to put you on the spot, but I remember we were waiting for that as a way to nail down our data.
It hasn't changed. They've kept it at 90 days. There was a lot of debate, and as far as my last update on the topic, it hasn't changed. And I really think this is an area that you're going to see a lot more discussion about, and a lot more hopefully sharing of information. You know, what states collect, we give it to CDC, and if they're able to combine data and provide us more of a perspective on this issue, we're hoping that we're going to see more focus on this in the coming days. But
thanks.
Yeah.
Great, thanks everybody. Next, we'll turn to Brittany Costello. Brittany, you are
Hi, thank you guys so much for your time. I was hoping that you guys could talk a little bit about the current testing going on in schools and how that relates to students. Obviously, we heard about the grant and the intentions, but I'm wondering if you could talk a little bit about what is currently happening. I know that there was the goal of 25% student surveillance testing. I'm wondering what we're at, if we are getting any of that done prior to this grant. Thank you.
Yeah, we had a little bit of a question about that last time, Brittany, on what was happening, and I texted the PED secretary. He said that most of their schools are meeting state goals for staff surveillance testing, and I don't personally have data from PED, the Public Education Department, about student testing at the present time. By any chance, Christine, do you know anything about that? We may have to get back to you on that one if Christine is not aware of current data on student testing.
I don't have numbers on the testing program, but I believe that it's really just getting off the ground. I think Dr. Petahone will have some updates on that.
Yeah, I think we can give like a better update next week, because this program, the testing program that's through this grant, just the contract just started this week. So I think we'll have better data on like who uptook, what's the uptake of the testing program, and more information for you next week. I think we can get that for you. Just to see, it's a sign up, so people sign up for it on the website.
All right, thank you. Next, we'll turn to Mike Smith, who hasn't had a chance to ask a question just yet. And then we'll, I think, dive back into the crowd of folks who already have. So Mike, you are.
Okay, thank you very much. Wanted to focus on some things going on here in the southeastern part of the state. I'm from the Carlsbad, Kern, Argus, and Eddy County, and I was wondering if you all could maybe address, speculate, however you want to term it, the sudden rise in cases that we had in Eddy County from Friday to Tuesday. We had 63 new cases on Friday and 138 during the 4-day or during the 3-day Labor Day weekend period. So wondering if you all could, what sort of answers you could all offer regarding the sudden rise in cases in Eddy County over a 5 to 6 day period.
Sure. So I think I'll start. So I don't have the report in front of me, so I'm just going to take you at your word that there were 63 on Friday, 138 Tuesday. So remember that Tuesday report, that would be a 4-day cumulative number. So what is that? That's like 30 some a day in Eddy County. So I don't know that that's an actual increase, and in fact could be a leveling off, though I'd have to take a closer look. I did pull up our level of community transmission report, which was just posted a short time ago. And in general, Eddy County still has high case rates, 92.3 per 100,000 persons, and a very high test percent positivity of over 14%. So we're nowhere out of the woods there, but it doesn't appear to me like that was an acceleration. I think we need to divide that by 4, and I think Secretary Grace is usually quicker at that.
Yeah, no, I'm sorry I didn't jump right in. I have been actually staring at Chavez, Lee, and Eddy counties every single day on the Epi report, and those numbers have been significantly high, particularly if you divide them by the population of Eddy County, for nigh on a month now for all 3 counties, over 100 cases, per 100,000 people per day, which is very, very high, particularly, it's more than 10 times the number of cases we think is what we can handle. And so I think Christine's explanation about dividing by 4 is right. I've made that mistake as well and freaked out a little bit when I saw the usually it's the Monday report. You could be even, there's even a better excuse this week because it came out, normally it came out on Tuesday for 4 days. Normally it's Monday for 3, but I haven't really seen a major change in the Eddy County cases per 100,000, which you can calculate yourself. You take your county population and just divide it into the cases, but it's been pretty steady and it's been bad. And it does seem to be leveling, I think, somewhat, but it's leveling at a high level. And so we kind of have our fingers crossed that that whole southeastern part of the state will see a downturn in the near future.
And I just wanted to add that was an excellent question, and thank you for asking it, because typically we do a cumulative report on Monday, and that's absolutely correct. What Secretary Grace said is that we allowed people a day off. So we did report that out on Tuesday. And so if that wasn't clear, that was 4 days of data, that could have sounded alarms for various people. So thank you for bringing that question up.
Yeah, as a bonus for asking that question, I just brought up today's Epi report, and Eddy County is at 31 cases, which is the first time they've been in below 100 per 100,000. And I apologize if this math is confusing, because only epidemiologists think of anything in terms of per 100,000. And so, but they're really used to it. So in any case, that is a positive trend. And some of the other counties I mentioned still way up there, but Eddy appears to be, at least for a day, on a downtrend.
All right, thanks so much, everybody. If folks wouldn't mind just briefly putting your hands, okay, looks like everybody's putting them up, so that works too. I think we'll start, as best I can remember, Julia was the first of this group to go last time, so we'll start with her again. Julia, you are unmuted.
Thank you, Matt. I just wanted to follow up on a question I had sent Dr. Ross related to the case hospitalization and death counts by vaccination status. The unvaccinated portion of those includes people that are partially vaccinated, as well as people who are fully vaccinated, but less than 14 days after their final dose. And I just was curious, I guess, what, of the 88.1% of cases among the unvaccinated, what proportion of those are actually people who have 1 dose or even 2 doses, but just haven't gotten past it. I didn't know if it was a significant, I'm assuming not a significant number, but also don't really want to assume anything. So thanks.
Well, another fantastic question, and apologies if you had sent that ahead of time. I thought your question was related to just, what was the definition and where did we include people? But I see you're actually asking for numbers.
Well, I sent it at 5:30 in the morning, so I probably wasn't very clear what I was asking.
Oh, no. I would say, let me get that number and I can get back to you, because that's another great question, but I don't have it at my fingertips. It'll take me a minute to pull that up.
Okay, thank you.
But Julia, another thing, and this is not about completeness of vaccination as it affects the case rates, the differential case rates, but it is about this constant 10% lag we see between people with 1 dose and people who've completed their series. And you heard Deputy Secretary Parahan, Laura mentioned that we're ticking along at about 1% a week. And so that 6-week period from your first shot to where you're immune with the Moderna, or 5 weeks with a Pfizer vaccine, from 3 weeks to the second dose, 2 weeks more to immunity. It is kind of reflected here in my own brain. I'm assuming that about 5% of people who got 1 vaccine won't get the second, and that corresponds well with about half. So it's certainly possible that, and now I'm getting to your question, I'm not going to give you an answer. It's certainly possible that some of those people that are the difference between these two have gotten or acquired COVID while they're waiting for their second shot, or that 2 weeks more for immunity for those who got 2 shots. So thanks for asking that.
Great. Okay, next we will turn to Dan McKay then Cedar Atanasio, then Brittany Costello. Dan, you are unmuted.
Hi, Dr. Scrace, can you elaborate on the possibility of an ivermectin death in New Mexico? Are you saying that someone took the medicine designed for horses as a potential COVID treatment and died because they took the ivermectin?
So, and Dan, you know how important it is in reporting the news to, have verification and evidence for your sources. But some people I've been working with for the whole pandemic, who I highly value their opinions, have informed me that they had a case in one of their hospitals die from taking ivermectin. And the belief is that ivermectin was obtained from a veterinary supply store. And so I have no idea how one would go about dosing oneself with ivermectin other than to make it really, really clear that one should never do that ever, no matter what. Like if you're a human being and you can hear this press conference, don't take the medicine. Yeah, but we generally wait till the cause of death has been confirmed by the treating physician. Not sure if this would become a case for the medical examiner, but it certainly could. And so it may take a couple of weeks for final confirmation, but reliable source, competent clinicians who really felt that that was the cause of death.
Thank you very much. I apologize. I don't remember if I said Cedar's name or Brittany's name first, but I think we'll just go with Brittany and then we'll go to Cedar after that. So Brittany, you are unmuted.
Hi, thank you again. I feel like I ask this question every time. So I know that you guys have talked at great lengths about the fact that we are going to be living with this virus. However, throughout this press conference, obviously you guys have some cautious optimism to your voice with some of the plateaus that we're potentially seeing. I'm just wondering, without predicting too much, I think that we heard early on that we might be in for a rough winter with all sorts of things, not just COVID, but RSV and flu. But I'm just wondering, if we keep up the good work, vaccinations and doing everything that we need to do, what do you think it'll look like after this surge? What the rest of the year would look like? Do you think we could see another surge in the winter, or do you think? I guess it's kind of open to interpretation, but I'm just wondering if you can kind of talk about maybe the future outlook.
Well, I'll start. Christine's already declared herself as not being a fan of predicting the future, and the problem with doing it is you're more likely to be proven wrong than right. But I think one thing we know for sure, Brittany, is that masks and social distancing are amazingly effective for preventing influenza outbreaks, because we didn't have one of any significance last winter. I think the answer, and I've been thinking about this a lot lately, is, we have a surge, we implement mandates, people respond, the surge comes down, we relax whatever mandates we have, then we have another surge. And I think we ought to all be starting and continuing a conversation about, what are we willing to do for the duration of this whole thing? We can't shut everything down. We tried that worked for a while, but it just, it's not a tenable alternative. How do we get to a point where we can more safely live with the virus? How can we get communities, not state government, but communities to step up and take individual actions to prevent spread in their own communities, like we're seeing in other places in the United States? What is a reasonable level of masking that we could all live with until the threat of recurrent surges is over? And so I don't think the public discussion about that is fully started, because we're kind of fighting the fires of these rises and falls in case counts. But I'm kind of hoping that these ups and downs can smooth out into sort of a steady state of a low number of cases that result from a certain amount of public health activity on all of our parts, a lot more people getting vaccinated, even more than we have now. I think we've got a great opportunity when the vaccine becomes available for 5 to 11-year-olds. I think that will be a chance to vaccinate a significantly greater number of our population. I'm excited that we keep seeing the vaccination rate go up by 1% a week. That's a big deal because we had data and survey data that people just wouldn't get vaccinated. So I think it's what is the long game, or what's the long-term strategy to live within a pandemic? And we talked, you might remember a year ago, I was talking a lot about the dimmer switch, not the on-off switch all the time, but the dimmer switch. And what as a society can we live with to get us out of this recurrent situation where we're, really making it extremely difficult for hospital workers and nurses, physicians, and others to just even continue in their profession because it's been so stressful. So I know that was a distinct non-answer, but if I could predict the future and make it happen, I would come up with some future where we all were willing to balance our own needs for individual freedoms with our own individual responsibilities to society. And we would, as a group, not every single person, because I get that, but as a group, come up with a middle way or an averaging effect of our public health measures and our and our vaccination rate and our response to these pandemics that we could all really live with. And so for me, I won't go into what I think I can live with, but we've been talking about a lot in our family, like what would I be willing to do? I'd like to get back to some aspects that I really enjoy about normal life, but so what am I willing to do to make those happen in a safe fashion and keep me safe and keep my patients safe and my vulnerable family members safe? And so I don't know, that was a classically non-infectious disease answer. Christine, I don't know if you have any thoughts about that, or Laura, what you're thinking from the vaccination perspective or other perspectives. Go ahead, Laura.
Oh, go ahead. Oh, okay, great. Well, I mean, for me, I think, on the team at the DOH that's working on equity issues, I think a lot of this is about, are we reaching the most vulnerable populations who have been disproportionately affected? And I think we're still not there yet. We've been working hard on getting mobile teams, but also working with community health workers and communities. And I think this next phase of the vaccination is also working on some of the ground game piece, which is how are we reaching out to community organizations that communities trust, Hispanic and Latino populations, even though I think 68% have, 68% of all children 12 to 17 have had their first dose. But for Hispanic and Latino populations, it's actually only 37% of those kids that have gotten their first dose. So I think we have to keep on, as a society, like David's saying, how can we also reach out to communities that have been historically marginalized or historically don't have as much trust in the health system? And so part of this is what we do as a community, I believe, to reach out and make sure that every person has access and the information that they need to make good decisions about, being safe and protecting their kids and their families. So that's kind of where I feel also that we're at as a society too, is like, how do we protect and reach out to different groups that have been disproportionately affected?
And Christine, any thoughts about influenza or RSV and this concomitant infections with COVID going forward?
Well, I hadn't thought of that yet, but what I wanted to mention was just this. I think this pattern has been established of surges and lulls. We see this happening globally. So it's very difficult to predict what we'll see in the winter, but the risk of another another surge at some point obviously is there. And I think just for me, the take home message is, we're not really going to be completely safe until everybody's safe, which means, we need to have really high vaccination coverage here in the United States. And we need to see the globe, around the globe, people need access to these just amazingly effective vaccines. And that's going to be the way out of this pandemic. It's a global pandemic. So I just think we're not going to be out of the woods until we are all out of the woods. So I see that as a ways away.
Thanks, everybody. We will turn to Cedar next and then see where we stand with folks looking to ask additional questions. Cedar, you are unmuted.
Well, thanks for your generosity. All your answers are generating more questions. So I guess I really just want to make a couple of requests. They won't require a response. The first is for as many details as you can share about that ivermectin, potentially fatal overdose, but also if there have been non-fatal overdoses this year. And then the second request, and I guess this would be for Dr. Parajon to keep in mind, is for this student testing. This would be really the first surveillance testing that's done. The program that has been going on the last 6 months didn't really exist. So if we can get results from those school encounters, it would be the first time that we have any kind of eyes on what the infection rates are in a particular district, for example, or at a particular school. So thanks again, as always, for doing this and just looking for, there's a lot of interest for that information.
Thanks
Yeah.
for pointing that out.
So, go ahead.
Oh, no, I said, thanks for pointing that out. Well, yeah, we'll get that for you next week.
Also, Cedar, I put that link that you asked for in the chat about a half an hour ago, but then I realized you didn't go to use. So if you look there now, you should see it. And on the ivermectin, we will start looking more closely. We'll get you whatever data we can get. I think I took a calculated risk of bringing it up without firm documentation because I don't want more people to die of an ivermectin overdose in the next 4 weeks while we're gathering data. And it's a word that I think is reliable, that I just like people to know that if there are people out there taking it, it can kill them. But I promise we'll get back to you as we get that official data.
Okay, would folks mind just putting their hands down and then, okay, Julie, you're leaving yours up. It sounds like it's a definitive desire to ask a third question. So we will turn to you. You are unmuted.
I'm sorry, I just sent it in the chat. I didn't need to ask it, but I just wanted, Dr. Schweiss, you said there's also a second person who you believe is in the ICU from ivermectin. Is that correct?
Yeah, that's what I've been told by people I rely on for accurate information. But obviously there are HIPAA issues and even location and names aren't things we can release at the present time.
Okay, thanks so much. I'm not seeing any additional hands. Any final questions from the group? I'll just give it a 5 or 10 seconds. Okay, looks like we've covered everybody. So any final comments from our panelists?
I would just say fantastic questions, and I have some homework assignments, and I'll get back to you with the information requested ASAP.
Laura.
Yeah, no, thank you so much. And yeah, we'll get back to you on the student testing and updates on that for next week.
Yeah, and I just thank you all. I do think, when we look at curves go up, we turn to you to help us get the word out. It's only appropriate, and you do get the word out, and you show up and you ask great questions, and that refines our approach. I mean, you have no idea how many times just some of the questions you ask have refined the way we approach things. And then it's only appropriate that when we see the cases not quite down just yet, but as we see them at least stabilize, to thank you as well for getting the word out to folks and letting people know. And I'm really interested in an ongoing conversation about what the future looks like and how we get through this in the long run, not just, wave to wave, but is there a strategy? I don't think, as Christine pointed out, we're seeing these spikes and troughs all over the world. And I don't think there's anybody that apart from, locking down the whole country at its borders, that's found a way to really completely suppress the virus. And even those folks that did that saw subsequent case outbreaks. So just appreciate your partnership, appreciate your attention to the details of things. And we do have some of those assignments, and we don't get back to you this week. We'll be sure to put those things into next week's press conference like we did this week from the questions we couldn't answer last week. So thanks. Have a great day. Stay safe. Wear a mask indoors. And if you haven't gotten vaccinated or you know someone that hasn't gotten vaccinated, please encourage them to talk with their trusted source of health information to talk through that decision. Have a great day. Thanks.
Thank you.
Thanks, everybody. We'll see you next week.